Chats, and thank you so much for joining us here today. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to empower families of premature babies through support and education. This Preemie Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us the experience and knowledge. Also on our website, canadianpreemies.org, parents will find all kinds of resources and support. One of our programs is the Parent Care Program. We are offering 4 free therapy sessions for families who are currently in the NICU up to 3 years post-discharge. It is a self-referral program, and all the information is on our website. And again, it's canadianpreemies.org. And today we are going to talk about how doctors break news to parents when their child has a disability. As we all know, children born preterm are at higher risk of brain-based disabilities such as cerebral palsy or autism. Neonatal follow-up is important to identify early signs that could suggest a disability, so intervention can be initiated as early as possible to improve functional outcomes and quality of life. However, communicating a diagnosis of a developmental disability is difficult for both parents and clinicians. The quality of communication process can shape how parents will adapt. This presentation will discuss the physician's perspective on how parents can ask questions and share their experience with their healthcare professional to foster resilience. And I have here, joining me live from Montreal, Dr. Thuy Mai Luu, who is a pediatrician, medical director of the Sainte-Justine Neonatal Follow-Up Program, and associate clinical professor of pediatrics at the University of Montreal. She's a clinical research scholar from the Quebec Health Research Funds. Her research focuses on long-term neurodevelopmental and physical health outcomes following preterm birth from infancy to adulthood, looking at risk and resilience factors along with best screening strategies to enhance clinical follow-up. She's also the director of the Canadian Neonatal Follow-Up Network, a research network including the 26 neonatal follow-up programs across Canada. Dr. Luu, thank you so much for joining us here today. I know you had a very busy morning, so I'm very grateful to have you here live with us today.
Thank you for the invitation. So as Fabiana said, I work as a physician in the neonatal follow-up clinic here at Sainte-Justine, but also in the complex care program of the same hospital in Montreal. So over the years, I've had to break sad and difficult news to families related to permanent neurodevelopmental disabilities like cerebral palsy, autism, or intellectual disability. So discussing diagnosis has never been easy because we know it will cause distress and pain. We want to talk about things that make people happy. On a personal note, each encounter where I had to communicate a diagnosis of neurodevelopmental disability has been unique and quite humbling. Some parents responded in shock, others were angry, others were surprisingly quite stoic or even relieved. I have unfortunately made mistakes when communicating a diagnosis, and I'm always hoping that I'm making less with time. This talk came from a chat with Fabiana where we each shared our experience from our personal perspective, me as a doctor, her as a mom of a premature child. And we thought that that talk could be the start of a conversation on how to improve the experience of hearing a diagnosis of neurodevelopmental disability, although we both acknowledge that it will never be the happiest and easiest days of one's life if that is going to be happening. Here, I'm really taking my clinician hat, not the research one. So this is not research I've done. This is really just my personal experience and observation. And of course, I'm trying to be as evidence-based as possible. I have nothing to disclose. So I will start today by discussing why communicating a diagnosis as early as possible is important. I will then share what should be the best practices from healthcare providers based on the literature. And I know that many healthcare professionals may not be aware of those best practices, but as a parent, I think that knowing about them may actually be useful, so that can be helpful for preparation. I will also be talking about the bad news response model, or how parents respond to sad and difficult news. And knowing about this model, I think, will be useful to discuss adaptation and resilience. So preterm birth, as you know, occurs during a critical period of development. So between 22 to 23 weeks up to term equivalent age, many organs such as the lungs, the heart, but also the brain are undergoing several maturational processes. As you can see here on the picture, during the third trimester of pregnancy, branching between neurons and organization of the brain will occur. And actually, the volume of the cortical gray matter will be increasing by fourfold. So this wiring of neuronal circuits is really influenced by endogenous factors, but also the sensory input and experience. However, the preterm brain is exposed to stressors that may alter its optimal development. These may include direct brain injuries, such as intraventricular hemorrhage or periventral leukomalacia, medical complications and interventions, but also the unadapted NICU environment. And so all these insults that can affect brain development makes the preterm brain at higher risk for injury, and also consequently makes the preterm infant at higher risk for brain-based disabilities like cerebral palsy or autism. But what is cerebral palsy? So cerebral palsy, really, it's an umbrella term to describe a group of conditions which are characterized by impairment of muscle tone, posture, and movement that will lead to activity limitation. It is important to understand that it results from a non-progressive injury to the developing brain. So that means that the brain injury should not get worse. It also means that if an adult gets a brain injury and has motor impairment secondary to it, this is not called cerebral palsy. The injury has to occur on a developing brain. Cerebral palsy can also be associated with disturbances of sensation, cognition, communication, perception, and seizure disorders. As I said, even if cerebral palsy is irreversible, children do not degenerate. It is different from a neurodegenerative disorder, and I usually stress this message to parents all the time because there's often misunderstanding of what cerebral palsy is. Children with cerebral palsy can only improve if proper care and early interventions are in place. That's because the infant brain continues to mature. So early diagnosis or high suspicion of diagnosis is important, so we can implement CP-specific early intervention that will take advantage of neuroplasticity to form new brain connections. So actually that can help the child function better. And indeed, 2 out of 3 individuals with cerebral palsy will walk, 3 out of 4 will talk, and half will have normal intelligence. CP-specific early intervention is also important to prevent or minimize secondary impairments or complications, such as pain, musculoskeletal problems, feeding, sleeping issues, visual function, or seizures. So it's really important to know about the condition so we can anticipate better and make sure that there's no complication arising from the cerebral palsy, or at least minimize the impact. Right now, the average age at diagnosis for cerebral palsy is 18 to 24 months, but we're really moving towards earlier diagnosis, and I already stated the reasons why. So now with existing tools and standardized protocols, which are really evidence-based, diagnosis could be made before 12 months in several cases, or even it's possible to identify high-risk infants before 6 months. And those clinical protocols include standardized neurological examinations such as the Hind, or assessment of movements like the GMA. And you may have seen or heard about these assessments. For example, the GMA implies filming, making a video of the baby movements and analyzing them. And when it's possible, getting a cerebral imaging can be very useful to establish a diagnosis. So although diagnosis can be made earlier, severity level may be more difficult to establish accurately. And that can take time, but doesn't actually prevent from starting CP-specific early intervention. Now, for autism spectrum disorder, autism describes individuals with challenges with social communication and interactions. And these individuals may have also presence of repetitive or restricted behaviors and or unusual sensory sensitivities or interests. And as the term says it's a spectrum. So some will be highly skilled, whereas some will require significant support in their daily lives. Autism can be associated with disturbances of sensation, sleep, mental health problems as individuals grow up, and gastrointestinal or seizure disorders. The first signs of autism are usually seen between 12 to 24 months, although there might be some early cues that are identified at 6 to 12 months. For example, a child which may not have the most optimal visual contact, a child who's not babbling as much or not responding to his or her name. Autism is typically diagnosed around 3 years of age with a multidisciplinary team. And sometimes actually the diagnosis follows a block of intervention with an occupational therapist or a speech and language pathologist, with the therapist observing that progress did not occur as expected. But sometimes the 3-year visit may be like the first time where we really notice that something is not evolving as expected. Now, something I always specify to families, autism doesn't mean that the child cannot be loving, happy, kind, and funny. And what's very interesting to know is that in the autism community, in an era where we are starting to recognize finding neurodiversity, individuals will say that they are autistic, not that they have autism. So it's really part of who they are. Indeed, also, like, we tend to see some of the deficits as something which is very limiting, and sometimes it can be, but also sometimes it can be viewed as strength. So for example, someone with restricted interest may have an ability to hyper-focus on a task, to pay attention to details, or have great memory, which can be useful skills for certain activities or tasks. Maybe they will have fewer friends, but they will be very caring and loyal to them, which is, I think, as important, or even more important than having 2,000 Facebook friends. So I actually had one parent telling me once, well, you're telling me that my child has autism, but really what you're doing is putting a label on him, and it's not really changing who my child is. And actually, I told the dad, you're not completely wrong. However, a diagnosis is important to better understand who the child is, so intervention, when required, is better tailored to his or her needs. It is also important to understand the child, so the environment or the behaviors by other people can be adapted to reduce stressors and optimize functioning. For example, knowing that an unexpected changes may increase anxiety, not because the child is being difficult, but because this is part of autism, may lead to better preparation when routine is anticipated to be different. When I was searching the internet for quotes, I found this very relevant blog from John Barbuti, who's working at the BBC and who has a son with autism. And this is one of his posts, which introduced very well the second part of my talk. And it goes, autism diagnosis, why finding out shouldn't be bad news. Wouldn't be great if finding out that your child was autistic wasn't portrayed as negative. What I recall of finding out our son is that every step had a tinge of negativity. It was this thing that you didn't really want your child to have if you were being honest. Do many parents with no previous experience of autism go into an appointment with a pediatrician and hope their expert opinion will tell that, yes, they are autistic? It is the negative that lead to the diagnosis. The eye contact not given, the other children not played with, the first steps not yet taken, even the toys not used in what is deemed the correct or normal way. When the diagnosis comes, the thought therefore is of loss, the loss of the future that might have been, the loss of the child you could easily plot out a normal life for. Did ease through school, did find a job, relationship and friendship would come. The negative shrouding of the entire process makes you mourn for the potential loss of normality. However, just because most people are not autistic, it does not make autism worse. My son is insanely creative. He is funny. He is original. He is energetic. Yes, he's weaker in some areas than many children his age, but he's also advanced in others. He's not better or worse than most other children. Well, he's definitely not worse. I don't mourn for a child we might have had. I embrace the one we did have. Yes, things are harder for him, but that's largely because the environment is harder. And that's why I look back on the process and wish it could be done differently. I wish it could be done in a way that didn't leave parents with the sense that there is one result they want and one they don't. So I thought that this testimonial really tells what I see in clinic. And we tend to focus on the negative, but rarely on things that we rarely give hope, I find. And this is certainly something that needs to be changed in the medical community. And I'm sorry if my PowerPoint presentation looks a little bit unstructured. I think I lost some of the mise en page, but oh well. So receiving a diagnosis for parents may evoke a threat to well-being, feelings of no hope, loss of future choices and lifestyle. It's associated with this distress and stigma. And for some parents, it may be a second grief after giving birth prematurely. And the parental response to a diagnosis may be very different from one to another. This might be influenced by parental expectations. For example, the parents who have been told in the NICU that their child was at higher risk of cerebral palsy because of a brain hemorrhage may receive the information differently from a parent who did not expect it at all because cranial ultrasounds were normal. Parental response may be influenced by previous experience, for example, if a family already knows someone in the family with autism, and also general personality. And as I mentioned in my introduction, responses are variable. There can be shock, anger, disbelief and denial, pain, or stoic acceptance. Really, there's no good or bad initial response. However, one thing is quite universal. The way the diagnosis is conveyed can shape parental mental health, trust in the medical team, and how the future is perceived. So really good communication is the key. I acknowledge that the medical community is not always good at that, and there is a lot of work to be continued to improve this part. And I know my friend and colleague, Annie Janvier, who's a neonatologist, ethicist, and parent herself of a premature child, is working really hard on that. So communication is the key because obviously diagnosis should not be delayed. And I already stated my point, but a diagnosis should be given as early as possible to optimize the child's potential from early intervention, and also to reduce parental stress and anger from diagnostic uncertainty. Because I have to say that most of the time when I communicated a diagnosis, even though it was very painful, very distressful for parents, somewhere they kind of knew and they were kind of waiting for this diagnosis to be finally made. And what I'm going to present next is a framework which was developed by Iona Novak, who is really a world leader in research on cerebral palsy. And she has written on best practice guidelines when communicating a diagnosis of neurodevelopmental disability. And this guideline is really designed for physicians. But I think that it's useful to know by parents, and it might give some cues on how to prepare. So one of the first steps that she's recommending is to prepare the environment. So that means getting a quiet, private place, having both parents, if that's applicable, and the child present, and leaving adequate amount of time. So if parents cannot attend the visit, or actually if it was not expected up until the visit that a diagnosis may be communicated, I think that it is totally okay to ask to put the other partner on a speakerphone. This is, everybody has a cell phone now, most have a speaker on it. So I think it's very reasonable to ask, and I wouldn't understand why a doctor wouldn't want to do that. I actually often offer it to family when the other person could not come. Or sometimes what can be done is also to arrange to a second meeting where the second parent will be present. And actually, when I said the second visit normally should be offered, it might be with someone else in the multidisciplinary team who has a closer contact. For example, for us, sometimes it's actually the physical therapist who does the follow-up appointment, or the speech and language pathologist, because they've actually seen the child more often, but it can also be the physician. And actually, if you don't have a second visit plan and you want one, you should really don't hesitate to request one. I think it's really important that follow-up to be done. The second recommendation is to understand parents' current knowledge before giving a diagnosis. So you might be asked, what have you been told so far? Or what is your understanding of how your child is doing? So this is the time for you to share your observations, both the positive and the negative. Share your concerns. And also, parents may have different perceptions. So there is really no right or wrong perception. This is the time to listen to everybody's point of view. The goal of asking parents is really to adapt the conversation, to update the information if parents were not at the same stage of understanding, and to clarify certain aspects up until now which may have been unclear. And really, both parents should have their voice, and maybe this is not the time to argue who has the right opinion or the bad one, because as I said, there's no right or bad reaction or opinion. The third recommendation is to ask and invite parents for questions. And some parents actually will have a lot of questions, and some parents need time to process and will have questions that will come much later. And really, you can ask your question now or later. There's absolutely no rush. If the diagnosis is unclear, this is the time to ask what it means. And often it's, we'll say the child has autism, the child has cerebral palsy, but really, what does it mean? What can my child do or will be able to do? What might be the challenges? It's okay to ask the doctor to speak, a normal language, not a doctor's language, which we often do and don't even realize. Some parents want to know about what the future holds. Actually, you can ask any questions you want. And if there's really something you don't understand, ask the healthcare professional to explain it and to repeat it. There should be no limits to the number of times we have to repeat it. The fourth step is to give knowledge and information to the family. And you don't need to know everything now. Some parents require more time to process, and that's okay. I've mentioned that before. And normally, we look at the nonverbal and we are kind of able to figure out if the parents are ready to get more information or not. But really, if the doctor is not very good at nonverbal reading, I think it's also okay to say, this is maybe too much information. Can we talk about it later, or can you provide me with written information? And actually, written information can be useful for later absorption. And also, it doesn't need to be a lot of written information. I had, for example, one parent, actually, after diagnosis of autism, usually we write a multidisciplinary report that we send to family. But because it's a long process, it may take some time for the parent to actually receive the complete report. So my mother suggested to me that I should actually now, which is something I do now, write on a piece of paper very simply, very clearly, what is happening, what is the diagnosis. And this very short letter is actually useful for parents to read afterwards and better absorb it, but it's also useful to show to other people, for example, at the daycare or to grandparents, so you don't have to explain. At this stage, after the visit, some parents may feel an urge to get as much information as possible, and that's completely normal. I would actually advise, though, against random Googling of diagnosis on the internet, because most often I find it just increases anxiety. And so here I've just put two really good websites. One is from CanChild, which is just an amazing website that I highly recommend to anybody who wants more information, or the Autism Speak website. But actually, the Canadian Premature Babies Foundation is also a really good resource to go to. And you know, like, information on the internet now can be very overwhelming. And most parents I've asked after who've told me they've done that, it actually got them more confused than, informed. So, if you don't know, just, ask the doctor or go to CBPF, who have really good resources too. As a fifth recommendation, and I'm going to quote here something I read on the CanChild website, actually, is be honest about your feeling. Guilt, anger, fear, anxiety, accept them all, because they are normal feelings. And very often, parents will apologize for their emotion. Well, you can apologize if you want, but you don't really need to. If you need to cry, just cry. If you need to be angry, just be angry. It's normal to have emotions, and actually discussing feelings and emotions are a really important step and will actually increase coping. And lastly, it's recommended to formulate a strategy and a summary. This is the time when you can discuss what you and your child need and want. Some parents also recommend that parent-to-parent or family support be arranged for long-term coping. So there might be resources in the community for that, or you might want the doctor to give you some resources on the web where you could go. Some parents want to know what they can do now and get practical tips. So it's always useful to ask. And if never or not provided, ask for a contact name and number. But for me, I work in the neonatal follow-up program, so usually the families already have our contact name and numbers. And do not be shy to use it, because although they have it, I'm always surprised how they tell me that they felt shy, they didn't want to disturb. And if we give you a number and name, it's really because we want you to use it. So going back to John Barbuti, he recently wrote this post, a couple of years later. The first one I think was posted maybe like in 2019, and he posted this one back in November. And it's a letter to myself on finding out my son was autistic. If I could write a letter to my former self, the me that has just been told by my wife that she thinks our son is autistic, this is what I would say. I want you to know two things. Everything will be all right, and there's no rush. You think you have a lot to process, but really nothing has changed. Your son has a label now, but it is one that can be used when it's useful and ignored at other times. It doesn't define him, but it will go some way towards you understanding how his mind works, and then wonderfully later on for him to understand more about his own brain. Now, how do parents respond to bad news? So there are 4 responses that have been described in the literature: the watchful waiting, the active change response, the acceptance response, and the non-responding, which is protective denial. And of course, what is associated with better long-term quality of life for everybody in the family is an active change response or acceptance response. The active change response implies the parent taking active steps to change the outcomes of bad news, whereas the acceptance response is accepting the bad news and accommodating their child. And depending on the pathway and how the child is evolving, a parent may be in an active change mode or an acceptance mode. For example, if despite a lot of therapy, there is the observation that it is unlikely that the child will be able to walk independently, the acceptance response may be more appropriate. So efforts can be deployed differently as opposed to trying to change the outcome of having my child walk. Another example, though, is if the child is in an active phase of development, an active change response may be more timely. So if we look at the active change response, we usually observe 3 types of behaviors. Parents will be seeking for information to be able to make the best decisions for their child. And they will also be seeking for information on how to establish a support network. They usually are very active in preventing deterioration and very active for treatment to improve their child outcome. But all this high activity to change things is associated with high levels of anxiety, also this feeling of never having enough information, and lots of energy spent in finding treatments. And parents often have this feeling of, did I do everything possible to help my child? So what is helpful for parents in an active mode is really to get good information. And this is really our role as healthcare providers, and probably like, the whole support network to be providing information on evidence-based intervention, but also to have open discussion on alternative and complementary approaches, if you are wondering. And I'm saying that because, like a lot of parents feel shy asking, but I think it's really important that you get your own ideas, speak with the scientists, and make your own idea afterwards. Because often if it's not discussed, then there's always this, background question on, did I really do everything? Should I have done more or not? And that also implies that the doctor has to be open-minded about alternative and complementary medicine. Coaching is also something very useful, and that usually happens through rehabilitation services or in programs where they have a parent navigator. And often writing down questions and answers might be very useful to come back to those. In the acceptance response model, there are 2 types of behaviors. Parents will then be more in the mode of sharing their story. And this is a way really to rewrite the story or to really cope with it. It can be very painful, but really it helps them accept what's the reality. And sometimes also it will be helpful for eliciting support. And then the second behavior will be accommodation, meaning integrating the child as he or she is into the family life, rethinking priorities, readapting the future. And I said I wouldn't show anything from research, but we actually had a project called the Parents' Voices Project that Fabiana knows. And actually, what we did was to ask parents over a year, the one coming to the Neonatal follow-up clinic in Montreal, a couple of questions. And one of them was, what is the impact of preterm birth on your life? And is it only positive impact, both positive and negative impact, or just negative impact? And if you had positive impact, please tell me what those were. And so I picked the one from parents who had children with a neurodevelopmental disability. And this really summarized, what happened, that resilience can happen, people adapt and actually get even better people because they see the world differently. And this is really something very positive the child is bringing to the family. So this quote from a mother of a child with autism: "My child is a miracle in our lives, and his strength and resilience give me strength and resilience. He's a joy to be around and brings light to anyone he's around." Another mother of a child with autism and intellectual disability shared, "She's alive and she doesn't take any medication." And trust me, she was actually very, very sick as a baby. "Her birth has taught to all of us to appreciate life." And the third one here, also from a mom of a child with cerebral palsy: "My child has taught us to stick together, to put things into perspective, to be patient." So how can we foster more optimal responses? So for preterm children at high risk, going through the neonatal follow-up clinic, it's really important to have a conversation if delays are observed, because that actually leads to better preparation if delays persist. So sometimes, in clinic, we'll see, often in neonatal follow-up clinic, we'll see children at very specific point, for example, the 4-month visit, the 9-month visit. And if there are delays, I think it's really important to share those observations and to discuss them and also to say what is expected in the next months. Because actually, if parents know what to expect and it gets better, well, everybody is happy. But if parents is aware of what to expect and it's actually not evolving the way that was anticipated, there's already better preparation than something coming, out of the blue. And actually, at all visits, if you have concerns, it's really important to raise them. And I actually get very frustrated when parents tell me that they have been concerned for language for a couple of months, but their doctor said, he'll grow out of it. I think maybe he will grow out of it, but I think it's really important for us healthcare providers to really be listening to them, to be supportive, provide written information if there's delay and there's something to be done about it, making referrals in a timely fashion, and help with care coordination. And I hope this is facilitated by neonatal follow-up programs, but I realize that it's not all children who are eligible for neonatal follow-up programs. So if you don't get this information, I think I would really suggest that you ask, what you're supposed to observe, what would be the next steps for further evaluation, and maybe ask for a closer follow-up visit. Actually, this should be standard of practice, but I've come to realize that sometimes this is actually not really always happening, unfortunately. Now, how we can foster more optimal responses once we get a diagnosis. And this is not me giving those advices. It's really from other parents. Once again, on the CanChild website, they conducted a study asking parents, what were their advice. And this post is very interesting. It's "If I knew then what I know now, parents' reflection on raising children with cerebral palsy," or actually when you read their advice, it's applicable to parents of children with any neurodevelopmental disorder. But some of the tips is really get informed and get people surrounding your child educated. Don't be afraid to ask questions. Be your child advocate, because you're actually the person who knows your child better. And don't try to do it all yourself. Get a support network, and don't forget to take care of yourself, which is something people very often forget. But actually, if you're not doing well, this is not going to be helpful for your child. It's like taking an airplane. They say if there's a lack of oxygen, there's the oxygen mask, put yours first and then the one to your child, because if you faint, that's not going to be very useful for a child. So in summary, preterm children are at high risk of neurodevelopmental disorders. But children with neurodevelopmental disorders have strengths. They can have a good quality of life, and they can be happy. So early communication of a diagnosis is important because intervention exists to improve function and prevent complications. An active change or acceptance response leads to better quality of life. This requires honest and sensitive communication styles from healthcare providers. And I guess, as I said, there's still a lot of work to be done. But, this is actually in CN in the Canadian Neonatal Follow-Up Network. This has been set as one of our priorities. And parents can be strong advocates. So ask questions, raise your concerns. If your doctor is not really good at anticipating things, maybe you can educate him or her and ask the question. And sometimes, it's not a matter of, not knowing, but I can see how physicians who are not used to give diagnosis feel very uncomfortable, and they feel bad, and then will try to protect, but actually, they're not doing the right thing. And I probably did that at the beginning. So, be an advocate, ask questions, raise your concern, say what works for you, what doesn't work for you and your child. And thank you for listening.
Hi, Dr. Luu. Thank you so much for your presentation. I had to tell you, I cried in a few moments because it was, this really hits home. As you know, my son was born extremely preterm. He has quadriplegic cerebral palsy, and you took me right back to the day we got his diagnosis, and I was like, okay, which response model did I fall? Which category I had there? But I want to discuss that with you in a little bit. I think my first question to you is, these recommendations that you shared, like the 6 recommendations, are incredible. So how are we disseminating this in all neonatal follow-up clinics in Canada? Because I feel that every clinic should have that. As a matter of fact, every pediatrician in the community who actually sees our baby should have that, because it's such an important tool. And as you mentioned, it does set the way we are going to ride on this road with our children.
Yeah. And you know what? Like, this was actually the first time I saw those recommendations, because I was going to try to read about, giving bad news, but more in general. And I just started, researching the literature, and I found that, and I was like, how come I didn't know those best practice guidelines? And actually, it really made me think about what I was doing myself and how I could improve. And the problem with practice guidelines is that many of them are beautiful, but then they get lost in, the literature, and it's the implementation that becomes the problem. But as I was reading that, like in the Canadian Neonatal Follow-Up Network, as you know, because you've been really involved, we're really trying to think about, redefining important outcomes, but also the process of, giving diagnosis, how to communicate also that the child is at higher risk of something. And by reading this, I thought this could be like a good starting point actually to educate, because it really has to do with education and implementation actually. I know that, for example, locally in different places, people like Annie Janvier, for example, who will be very active in educating the residents and the medical students. And I think actually the medical curriculum, the communicating part is becoming more and more important. So we're hoping that the next generation will be even better than the old one. So now I guess it's really making sure that, those who didn't get this education previously are knowing about, are knowledgeable about these guidelines. And this is really, part of continuing medical education, but not just that, really like getting from medical education to implementing it in practice.
So I have a question for you in terms of our perceptions of disability, right? Because there is a communication piece that we can give them to the students or the residents, or disseminate these guidelines in clinics across Canada, but also how it is a moment to review our own perceptions of disability, because no matter how good communicator you are, and if you still feel that disability is a bad thing to have, or how are we going not to be in bias of our own perceptions, but really support the parent in that moment, because it is a life-changing moment, as you present in your talk. And I always do. There is we always bring our experience and our perceptions when we are communicating, right? Like, because I heard, okay, I'm sorry your child has cerebral palsy, right? Because I see that somebody might see this as a bad thing. So I would just want to hear from you. What is your take on it?
So I think this, this comes really from our deficit-based perception of everything in medicine and in research. This is really how we're trained. We're trained to identify the bad things, but then we forget that there's actually something we can do about it. But we forget about the strength. And this is starting to change. Like every year, I've started reading about a strength-based approach. Maybe like in the past 2 or 3 years, and I feel that every time I'm trying to look at the literature again, there's more and more coming out. So I think it's positive, because I think it's moving in the right direction, and it also goes with the movement of neurodiversity, and also I think EDI. I think we're accepting more and more differences, but this unfortunately will take time, because this is not how I was trained, and I'm not sure actually it's part of the medical curriculum. So it's really, and I think you've seen it in the conversation we had within CN Fund, it's changing this mentality of seeing everything as negative and having this balanced view. And at the same time, we shouldn't be sugarcoating things, because, parents actually don't like that either. I remember, one parent telling me about, when I was a resident, I can't believe, this didn't tell me that my child had cerebral palsy, and she probably knew like 6 months ago. And I know this doctor was actually wonderful, a great physician, but I think she was afraid herself to hurt, so it's really finding this balance of, okay, it's not going to be I'm not going to give you what you want me to hear. So let's name it, let's label it. But there's also, there are also strengths. And I think we often forget this part. And I actually find it much easier now, but it's not easy. It's still not easy because, like if you had the choice, I don't know, if you would have the choice, you wouldn't necessarily pick the diagnosis. But hey, this is how your child is now. So there's no point being overly negative. It is hard. It is difficult. There will be challenges. But hey, this is also what your child can do. And I think that we forget about what the child can do, and we focus on what the child cannot do. But this is changing mentality, and it will take time. And I actually think that parents have been very good at advocating for that. And actually, for the autism part, I was, I'm part of an education thing where we have someone in the team who has autism, and actually he's the one who told me, like, no, I don't have autism. I am autistic. This is how I am. I'm different. And and actually I also read, like, if everybody were autistic, me actually be the one who's different and wouldn't fit in, so it really depends on perspective. But I think the whole society is slowly changing, and that's probably because of parents and also individuals who are different. And I strongly encourage, advocating more, but at the same time, not, sugarcoating everything, because parents will say, hey, like, it is difficult. Don't tell me a joke that it's going to be a piece of cake. But that, that makes, I think, those individuals and parents even stronger.
Yeah. Wow. Your work, I find, like, really, really, really amazing, because you're really changing the perceptions and how we communicate. And I think Canada is really leading this, what I'm going to call movement, because for a lack of other word, in changing those perceptions. Because I participate in a lot of parent organizations meetings, and there is no such a conversation, right? We still see, okay, disability is a burden. My child is not fully integrated or involved in activities, because there is still a lot of stigma, but also lack of resources. And I feel like with your work with the CN Fund, we're really changing that, but also because you are very good, and many other groups in Canada, like a Can Child, the Child Bright, they are bringing the parents to the table. They are bringing the children to the table. And then the community start to see those children that were born preterm, who have neurodevelopmental disabilities, to see later in life, right? Because you see the neonatologists, the follow-up clinic, most of them are neonatologists. They see the babies in the NICU a year, 2, 3 years after discharge, and then you don't see the life that we live after. And I think that is important to see, that, to change that perspective, that perception that, okay, yes, my child has a disability, and my child can sing, my child can participate in the classroom, can participate in other activities. And that's the piece that I feel we're going to start to change. But I love the way you mentioned the communication and the breaking the news piece that sets the journey ahead. But let me share some of the comments that are coming here. You have here from Katie. Hello, Dr. Luu, thank you for the presentation. I have a family whom I share my observation with. Mom didn't agree with me, and she would like to wait and see approach. So there's a continuation. I let her process my observation to the next appointment. Do you have any advice for my next appointment with her? Thank you, Katie, for asking your question.
Yeah, that's a very good question, because I've had that. So sometimes actually, like, wait lists are quite long. That's I don't know if it's the same thing everywhere in Canada, but in Quebec, if I want speech and language therapy, it's not as if it was going to happen, the next day. So I tell parents that, okay, we can wait and see, but and this is what I'm expecting, but I'm still going to take actions. Why? Because the services will not come right away. And even like for children where we suspect autism, I'm going to say, well, like this is worrisome to me, and maybe this will go away, but maybe it will not. And if it will not, I don't want to be waiting an extra 3 months. And if, I ask the services, and when, it's his or her turn, he doesn't need it, well, good. Good for him. But, if he still needs it, we don't want to regret that, times has passed. Now, I also explained, and I think like the parents, the reason for the wait and what is really the stigma that is associated with it. And this is really like, that requires a whole change from society. And I can understand, why, a parent wouldn't want their child to have a label of autism, because it's still very stigmatizing, and in certain communities, it's it's the parents' fault, or maybe you didn't raise your child okay, and so it's very stigmatizing, and I can understand why they don't want me to put the label. So I will explain why I'm putting a label now. It's really to get services, and really like this label can be, and as it's said by the by John Barbuti, this is a label. It doesn't define who your child is. It's useful now because it's necessary to ask for services. But if you don't want to give this letter, you just keep it to yourself. So actually sometimes what I'll do is let me though like make the referral for early intervention or for rehabilitation services. This is the letter. I'm not going to share it with your personal doctor. I will let you share it if you want to share it. I will let you share it with daycare if you want. And that's sometimes wait. But what I don't like with the wait and expect is because, it's the waiting list. And we know that if the child can benefit from early intervention, we shouldn't wait. But sometimes for autism, what I've done also is, I speak to the early intervention and I say, like, you don't really need me to write autism for you to start initiating something, and work on interaction. And so sometimes it is possible to not, well, I know it's difficult, but sometimes it's possible not to put the label, but still work, work on early intervention without putting a label. But I have to say that that's a little bit harder. I've done it before with parents who really, really didn't want that, but understood the need for something more specific to their child. I don't know if that's helpful.
Okay, thank you, Dr. Luu. One last question. When you talk about the response model, there's 4 different ways to respond. Do you feel that parents go from one response to another within a period of time of their journey? Because I felt like, okay, at first I was in denial, then there was acceptance, and I felt that I went through some stages until I fully embraced my child. And said, okay, now this is what I have to do.
Yeah, so I think, the response, I think there's the response model, which is more like, how you're going to respond over time. So, and then there's the grieving process where, first you're in total denial, then you're really, really, really angry and you're trying to negotiate something with, whatever. And then once you accept, then this is where you become more active. I think this response model is more maybe like long-term. So someone who stays in denial, and unfortunately, I've had that family saying, you know what, like, I don't think my child needs intervention. I don't think he needs special adaptation at school because, he's or she's totally fine. Unfortunately, over the long term, somebody's quality of life is not as optimal. And so, so I think like the denial is really part of the grieving, and it's you probably were in denial, but probably still got the information. So it's a little bit different. So you can still be in an active mode, but in denial because you're still grieving.
Okay, totally makes sense, because so I heard many times that we go through the same stage of grieving with new diagnosis or early delivery of the baby. So it totally makes sense. So Dr. Luu, thank you so much for joining us here today. It was so lovely talking to you, learning from you. I wish you could multiply you in many clinics across Canada, because you really bring a fresh approach a very empowering approach for families. And I think that's what we need in this community, because we go through so much in the ICU, and then you add the diagnosis later. And you really need to have this amazing village like you are supporting families. So I really want to thank you for your presentation today.
It's my pleasure.
And to all of you watching us live here today on YouTube, Facebook, or Twitter, thank you so much for joining us today. And the video of today's sessions and all the videos from our live sessions are available on the CPBF website, which is, let me show here, the CanadianPremise.org. And I want to thank our sponsor, AstraZeneca, for supporting our education sessions. And CPBF is a charitable organization, and we believe that through support and education, we can empower families, ensuring they're ready to care for their babies. Please visit our website, consider making a donation. Together, we can create a brighter future for all families. And we'll see you again next Friday, 1 p.m. Eastern Time. Thank you, everyone.